Hello, everyone. Let's see. Okay. Excuse me. Voice a little hoarse this afternoon. Welcome. Thank you for joining today's Smart Round. We're very thankful to have our friend and esteemed faculty, Dr. Christopher Jackson. Dr. Jackson is Associate Dean, Student Affairs, Associate Professor, Internal Medicine, Department of Medical Education at USF, Morsani College of Medicine. He's also a fellow of the American College of Physicians and most notably past president of the Southern Medical Association. Tonight's Smart Round will be a case-based session that will use the Curbside podcast to help attendees develop a systematic approach to the diagnosis, workup, and initial management of patients with dementia. Interactive polling and case-based discussions will be used tonight to help make this session more engaging. You're also encouraged to use the Zoom tools throughout the presentation. You can raise your hand, chat, click the reaction, or post a question using the Q&A button. All of these tools are available at the bottom of your Zoom toolbar. Dr. Jackson, the floor is yours.
Thank you so much, Randy, for the kind introduction. It's a pleasure to be on tonight. And again, I just hope to be able to start a conversation about dementia. It's something that certainly impacted my life, both in a personal sense, with grandparents, and then professionally, taking care of patients. And so I hope by the time we end, you feel at least a little bit more comfortable with the diagnosis and management of dementia. Give me just 1 second now, and I'll share my screen. All right. So again, this is a Dementia SMA Smart Rounds, and we're going to be utilizing the Curbsiders podcasts. I'll be using this interactive tool. It's called Slido. For those that have used Poll Everywhere, it's very similar. All you would have to do is you can go online to slido.com using that code, and you'll be able to get into the polls that we'll be using during this session. You can also point your camera towards this QR code, and looking at this QR code, also be able to access the polls that we'll be using. Don't be alarmed if you go in and see there are no current interactive polls. That is by design. As we go through, there will be some different interactive polls that I will have. Again, as this is a CME activity, just want to start by saying, related to the content that is present, I have no relevant financial disclosures or anything related to the content of this talk. So, Randy mentioned that we're going to use the Curbsiders podcast. And so what I want you to do, and I'm going to see if I can move this out of the way so that you can do, is I just want you to take your camera, and if you open up this link, it should take you to a Google Docs file that has the Curbsiders podcast information. This was Curbsiders podcast number 268, looking at dementia made easy. And if you're able to access it, what I want you to do for just a couple of minutes or two is just to peruse it. Again, not getting tested on or anything, but I just want you to peruse, see what you find there. And then when you do that, feel free to put in the chat or anything, any comments or curious things that you find. So I'll leave this up just for a second. Again, I'll give you just a couple of minutes to just look through these podcast show notes. Curbsiders is one of just very many popular internal medicine podcasts. And what I want us to do is be able to use the foundation of these show notes to really push forward a conversation regarding it. And I'll give you a minute or so. I'll stop my share just briefly, make sure I'm not missing any comments or chats or anything. Perfect. Let me hit my share again. Another 30 seconds. And okay, looks like maybe some things are coming up there in the chat. Andy, if you don't mind, just sharing if anybody's bringing any interesting things in the chat before we go forward.
I'm going to see if I can put that link in the chat. Yeah, I was able to get that Google Doc in the chat there. So if somebody has trouble with the QR code, you can just click the link.
Excellent. I'm just going to stop, share one more time, just make sure. Okay, got it. Perfect. Let's keep going. So this is the first poll question that I have here. Just what comes to mind when you think of dementia? This could be, you patient scenarios, things like that. But when we talk about dementia, just that word in of itself, kind of what kind of things come to mind. Um, and as you respond, it should be able to show up on this poll here. So I'll give just a little bit of time here at this poll. What comes to mind when we think of dementia? Okay. Confusion definitely is one of the things that I think about a lot and often is a nagging thing for patients and families. Ooh, I like that broad term for a lot of things. We will talk about trying to get specific because there is both treatment considerations with that, but also prognostic considerations too. Give a few more seconds here. Fusion. Broad term for lots of things. Anything else come to mind when we say dementia? Just going forward, let me ask a different question. How confident do you feel in your knowledge about dementia? Very confident, somewhat confident, not confident at all. And how do you feel in your confidence about your knowledge of dementia? Okay. Couple of votes, somewhat confident, not confident at all. And all of these polls, by the way, are anonymous, not uh, can't track who says what or anything. Um, Okay. And just give a few more seconds for anybody else that wants to vote. Again, you can join either at the website there, you can join via QR code too. Either works. All right, so I hope we'll be able to move the needle a little bit and make you hopefully feel a little bit more comfortable by the time you get going. And so let's jump right in. Let's say got a 78-year-old man evaluated 4 months, increasing forgetfulness, lives alone, maintains independence in all activities of daily living, instrumental and basic. Daughter reports, forgets appointments, and home is less organized than before with more clutter, including unopened bills on the dining room table. Does not drink alcohol, no history of high-risk sexual behavior, otherwise well, takes no medications, on exam, vital signs, general screening, and neurological findings are normal, can recall 2 of 3 items on the mini cog test, but cannot correctly draw a clock face. And so the questions that I want us to think about right now is difference between mild cognitive impairment and dementia. What screening tests can we use for cognitive impairment? And then what are the 4 common causes of MCI that merit consideration in this patient? So I'm going to stop right here just for a second and see if I can invite a little bit of discussion in the chat. Unmute yourself. Mild cognitive impairment, dementia. What's the difference? How do we tease between the two? Or is it just one and the same? And you can feel free to put in the chat or things like that. And I'm
Yeah, you
going
can
to,
you can chat, post in the question, or just go ahead and hit any of the tools, and I can open up your mic if you'd like to say something.
it might take a little bit of silence there, like, there is this fine line and what exactly is it? So I'll come back to that in a second. What about screening tests? What can we do in the office? I'm a primary care doctor by training. So I see this in the office all the time. This is a very common concern that's sprung up, particularly for my patients as they get older, if they have family that's coming by. What can we do in the office with our wonderful 15 to 20 minutes to see the patient? You can drop in the chat, what can we do for this patient? And Randy, I might enlist your help if someone is dropping things in the chat just to help me there too.
You got it. I'm keeping an eye on it.
Thank you, sir.
Hi, Dr. Jackson. It's
Yes, ma'am.
Jennifer
Yes.
Price. Very quickly, I just wanted to touch on briefly that some of what you're talking about has kind of hit home just from some things that my mom went through last fall. And it was interesting just to hear you talk about some of these simple tests, the clock face especially hit home.
Mm.
Because I always tease her sometimes if, she's on this side of 80 versus, she's getting older versus, because through all of her health trials and tribulations, she's worried about losing her mind. And so just this is a very informative conversation for me. And a lot of what you've said in just this first slide has hit home.
Mhm. Well, thank you for sharing that, Jennifer. I'm sorry that your mom is navigating those challenges, and I hope she gets support that she needs. And I hope that what we'll talk about be very helpful.
Just really quickly, we're fortunate that after she came back from rehab, that she regained most of her cognitive function. They thought a lot of it was infection and just being hospitalized for a while. So we are fortunate, but I'm looking forward to hearing more about this as this presentation goes on.
Mm. Absolutely.
Hey, Dr. Jackson.
Mm.
Adrian has a screening tests for causes, syphilis, anemia, vitamin deficiency.
Okay. Awesome. Awesome. Love it. So let's dive in. When we say MCI dementia, it's really a spectrum of the patient's baseline, their cognition, and whatever their level of impairment is. And it's where these things intersect that we can say something is normal aging versus MCI versus some form of dementia. So the way I like to think about it is something like this. So normal aging, there can be infrequent memory issues. But when I say that there's preserved cognition, it's usually to say, that, on some form of testing, but also in terms of, level of consciousness, things like that, there shouldn't really be any impact. So normal aging might be, yes, I might misplace my keys here or there, but if you ask me orientation questions or you did some sort of other cognitive testing, I would be totally fine. Mild cognitive impairment, the frequency of the memory issues do go up. There is definitely impacts on cognition, but when we do test, whether it is recall, MMSE, etc., there's usually minimal impairment. And then with dementia, there can be even more frequent memory issues with, frankly, a little bit of apathy about those memory issues, as well as cognition impacts. And then on testing, whichever we do, there will be more significant impairment. Now, there are all these different tests for to screen for dementia. There's the mini cog clock draw, there's slums, which initiated, I think, out of the St. Louis VA. There's the mini mental status exam that many of us train with, and then there's the Montreal cognitive assessment. My question to you is, which of these is most effective? Because when I'm in the office, I have to make a decision pretty quick, with my 15 minutes or so and the patient's concern of this, as well as their diabetes, their CKD, their blood pressure that's not controlled. I need to make a determination. What tests, what screening tests am I going to use, and how am I going to use it? So, um, what might be most effective? If you had to rate these from 1 to 4. Okay, got to vote for Minicog 1. And then a tie between the other three. Anybody else weigh in here? Okay, now maybe a tie between Minicog and Mocha, and then Slums and MMSC at the bottom. Okay. So let's dive into that a little bit more. The mini-cog is commonly used. So the mini-cog usually is a test of drawing a clock face and putting like it's 10 past 2, and then can you recall 3 words? And overall, it has decent sensitivity. That is to say that a completely negative mini-cog test makes it highly unlikely that you do have dementia, but its specificity can be quite variable if you see between studies anywhere from 27% all the way up to 85%. So as much as I love it from a sense of it being practically quick to do in the office, it's just really okay. If I go to, slums, slums is actually a little bit better on both sensitivity and specificity. Depends upon what cutoffs you use for cognitive impairment and dementia, but relatively speaking, it can keep pretty decent sensitivity. It certainly has higher specificity. That is to say that a positive test means more likely that you can rule in the diagnosis of dementia in the right context. But it is longer to give, hard to think about in the office. And then what about mocha? So mocha, again, very good on sensitivity, um, probably similar in terms of specificity of the slums. I will say slums is a little bit shorter than mocha. And so depending upon where your clinic set up or your hospital set up, some really like mocha because it's been around, validating a lot of things. I used to work in the VA system. We use slums a lot. I think the thing to take away from these tools is to recognize their limitations. So for me, if I have a very low clinical suspicion, a mini cog done quickly in the office, I feel pretty good. Probably it's not. But if I have a reasonable suspicion, I probably need to be using something like Slums or Mocha for better assessment. MMSE, beyond the fact that it's copyrighted and sometimes very hard to get, actually, from a sensitivity standpoint, does worse than Minicog and Slums. And so I would say for me, it's not something that I go to as often as much now. I kind of start with Minicog if my suspicion is low. If my suspicion is high, then I'll do Slums or Mocha instead. That is just my own personal practice. But whichever test you do, I think it's important to know what are the cut points for when they can be helpful. So in general, with mini-cog, if it's 4 or less, you consider MCI, and if it's less than 3, you consider dementia. With slums, they use a cut point of 24 and 19 for MCI dementia. For the MMSE, for those that still use it, less than 27 is mild cognitive impairment, and then less than 24 is dementia. I will say, though, that there is an issue with kind of educational attainment, particularly with MMSE, that those with higher educational attainment might actually end up getting higher scores on it, and that can sometimes be a bit of an issue with diagnosis. And then the Montreal Cognitive Assessment really isn't set to diagnose MCI, but it can help with dementia. Now, this patient, if I went through the testing as I kind of had in the first slide, probably fits more a mild cognitive impairment. If you did a mini cog on them, it's like 4 out of 5. And so when I get these patients in the office, it's really important for me to look for some core things. Is it medication adverse effects? Check the meds, antihistamines, anticholinergics, things of that nature. Is it alcohol misuse? Is it new depression? And then one that is very near and dear to me is sleep apnea. If you're not sleeping, you're going to have impaired memory. And so even with mild cognitive impairment, I think it's important to think about just these common causes, because pretty much for all of these things, we can do treatment and make a big impact for our patients. So again, cognition, memory, testing, and level of impairment kind of helps you think through, whether it's normal aging, mild cognitive impairment, dementia. And if it is mild cognitive impairment, keep these 4 things in mind for the patient. But let's keep going. Let's say I give you a 78-year-old woman, evaluated 1-year history, progressive worsening memory impairment, can no longer handle her finances, doesn't remember how to fill out checks properly, lives with her spouse and is independent in her basic ADLs, but you do a MOCA and it's 21 out of 30. So we do worry that this is, again, in that dementia category, and then has normal labs. And so let's think through a little bit what lab studies are most helpful, what findings on imaging are most helpful, and then what preventive measures, if any, can be taken. So let me go forward with that a little bit. In in any sort of cognitive impairment, there are a whole host of tests that you can take. This figure is taken from an Annals paper looking at dementia, and you can see there's a whole host of tests, CBC, TSH, vitamin B12, CMP, and then some additional tests based off exposure history. I think a couple of important points here. There are really only a couple of labs that are kind of considered that top tier, probably most all patients with dementia should get. And the vast majority of labs really should be in that kind of second, third pass. So for me, TSH and B12 are kind of high up there in terms of, testing in most patients that are having some degree of cognitive impairment concern for dementia. But then, really, all these other tests really should be guided by clinical suspicion. For example, an HIV test, HIV associated dementia, again, would have to have a relevant exposure history. And again, this is going to be somebody whose CD4 count is pretty low, their viral load is extraordinarily high, they may or may not have been on treatment. Um, RPR, again, relevant exposure history, maybe or maybe not treated in the past. So don't just reflexively order all these things. Again, kind of think judiciously. So again, TSH, B12, probably highest yield up front. CBC and CMP more helpful as other clinical clues. I always say beware of incidentalomas here. Part of the reason why you don't want to go just like reflexively ordering every lab is, you get an RPR on somebody that hasn't been sexually active or have any other risk factor, and now it's 1:1, and you have no previous testing. Well, now you got to figure out how much you need to evaluate or figure out is that a cause or not. Because even though I would say that that titer is low and probably not the cause of the patient's cognitive impairment, now you got a positive test and you can't just like let that go. Now, neuroimaging always comes up like, should we image the patient? And I would say Um, you could probably make an argument to image most patients, but there are certainly some patients where imaging is going to probably be the highest yield. If it's cognitive difficulties for less than 3 years, if they're having rapidly progressive neurodeficits or focal abnormalities on exam, if their consciousness is fluctuating, that would make me concerned. They're having frequent falls. All of these can kind of point you to some different things. Okay, so let's talk through some just neuroimaging here. Okay, and so um, of course, you might order CTs, MRIs, and things. And so I'm curious if anybody, whether in the chat or mute themselves, et cetera, can tell me what's going on with the image on the far left. Oh, you had somebody come in, they've been having some memory deficits, maybe have some weakness on their neuro exam. You decide to get that imaging. You see that. What's going on? And you can put it in the chat. I think there's even a feature of Zoom you can annotate and say on the slide what's going on with the patient on the far left of the screen.
You see that, Dr. Jackson?
I saw it light up, but unfortunately I can't without stopping my share. I wouldn't be able
Okay.
to see what I'm seeing.
Chronic SDH.
Yes, to whoever said that, yep, that's definitely subdural hemorrhage, classic, grandpa has not been doing well. They had a fall, and ever since that fall, they've been having more memory deficits, etc. What about the next image there? So to the right of the subdural hemorrhage, what's going on with that picture? Having memory deficits, you decide to get some imaging, you see that lovely thing. What's going on there? That lovely image would be an abscess, so this be brain abscess. Probably someone had kind of extension of an odontogenic focus of infection or something of that nature. What about this image here? What's going on here? You might even complain of feeling of vertigo.
Also, unmute your mic if you just like to speak. It's probably easier. Just unmute your mic, anyone. I do have there is another chat. I'm going to take a shot at this. Cysticercosis.
Okay.
Cysticercosis.
Cysticercosis. Okay. Yeah, very close. I'll come back to it in a second. And then, so that's a hemorrhage. That's abscess. This tumor probably most consistent with a meningioma, particularly with this tail of it right here. And this would be hydrocephalus, particularly like normal pressure hydrocephalus that can happen. The classic wet, wacky, wobbly is what, we're all taught. Now, one thing that this brings up and something that I've talked with patients about is, Doc, I don't want to get dementia. Like, how do I make sure that I am, not going to have to worry about this? And the truthful answer is that I wish there was just like one particular treatment or one particular thing that could do it. We have some things that I think are in the green light area. We have some things that are in the yellow light area, and then some things that are red lights. So starting with the green lights, I think certainly any medications that we can deprescribe that have, impacts on mentation and things, particularly for those patients that are older, probably is one of the best things we can do for prevention. So the anticholinergics, the benzodiazepines, chronic antihistamines, all this very important. There is a pretty good and decent amount of data on physical exercise. So, maintaining exercise anywhere 90, 150 minutes a week. There really isn't a focus on whether or not it has to be this component aerobic or this component strength, although I will say probably most of the data is around aerobic. Those are things that I think we can say pretty good are the green. We have decent evidence, minimal risk of harm. Yellow light, there is something to be said about hypertension treatment. There's been some studies like looking at MRI changes in those that have, blood pressures controlled to less than 130 or less than 120. And, if you control to those degree of blood pressures, you're less likely to have those changes on neuroimaging. I put that as a yellow light because I can't necessarily say for sure that because there's less changes on the imaging that you are less likely to have dementia, but certainly there may be a correlation. Cognitive training, which is a pretty broad swath of things, anything from, kind of mental games to other things to kind of keep mental stimulation, that might also help. I wanted to also show, though, the vast amount of things that are a red light. So ginkgo biloba, B12, omega-3 fatty acids, statins, vitamin E. again, it's not to say that these things might not be helpful in other contexts. I just can't say that they are overwhelmingly helpful for preventing dementia. And so for the patients that we talk to, or even for ourselves, I think staying as active as we can and being judicious and mindful of the medications we are on that can act on cognition, probably the best things we can do to prevent. And then right after that would be, again, control of things like hypertension. I would also put kind of a little caveat in there, also control of diabetes as well. But these are the things, at least current data would suggest, are the best ways to prevent. So there is kind of a, diabetes prevention framework. This was presented in Lancet. And so what you will see is, they kind of mention a few things: minimizing diabetes, treating hypertension, not smoking, um, avoiding excess alcohol. And then I think what is interesting and placed at the end that's very important is, making sure there's not things like isolation. So maintaining frequent social contact. There is a protective factor regarding education level and development of dementia. Making sure there's no hearing impairment. Why? Because these things impact your cognitive reserve. Treating diabetes, hypertension, not smoking, reduces this neuropathological damage. And all of those things feed together into preventing dementia. And so, while I can't say that there is a one size fits all, I do think it's worth kind of considering the impacts of these different things for your patients, and therefore kind of determining like what is that kind of dementia prevention framework that would work best for them and their needs. Any questions about that before we move a little bit more into treatment? All right, let's go into treatment. So I have a 71-year-old. He's a retired university professor, and he has 9 months of difficult to manage behaviors and slow gait. He has intermittent forgetfulness and inattentions, gotten lost while driving, had visual hallucinations. Family members report that his affect has become more blunted, no other medical problems. Vital signs are normal, but on exams, got mild agitation, impaired recall and figure drawing, a mass face, muscle rigidity, hand tremors, and a slow gait. So, what features kind of help us distinguish amongst the 5 different types of dementia? Would anticholinesterase inhibitors have a role in this patient? And what about antipsychotics? I think somebody brought up a great point earlier that when we say dementia, it's a little bit challenging to use the term because, again, there's so many different subtypes. And with there being so many different subtypes, if we're not careful and just use this blanket term, we might be missing the opportunity to meaningfully impact and help patients. So, if you can, just in the chat, give me some things that could help us distinguish among the different types. And I'll start off by just saying when I say different types, I'm thinking Alzheimer's, dementia with Lewy bodies, progressive onset dementia, things like Creutzfeldt-Jakob disease. What things help us distinguish amongst them? What do you think?
Parkinson's.
Definitely Parkinsonism. And, sometimes the difference between Parkinson's disease with dementia versus dementia with Lewy bodies is the latency time between the Parkinson's disease, or the latency time between the onset of dementia symptoms and their degree of Parkinson's. Totally agree. What else?
You can unmute your mics as well if you'd prefer to speak out.
So we're wrestling a little bit with this. We'll do just a simple poll in the chat. Would anybody go ahead and give this patient anticholinesterase inhibitor? You can put a Y for yes or an N for no in the chat. Does this patient get an anticholinesterase inhibitor? Y for yes, N for no. And as a follow-up to that, would you give this patient an antipsychotic? Yes or no? These are some challenging questions, that we have. Again, not all dementia is the same, and, not everybody just goes to the exact same treatment. So I wanted to give a helpful figure. I love this from the NIH. It kind of helps us think through different types of dementia. So Alzheimer's is kind of the classic. Usually, it can be from mild in severity to severe, going to be usually in the mid 60s and above, unless there's some case of early onset Alzheimer's where it can be between 30s and 60s. You have frontal temporal dementia. You're going to usually see more behavior issues there. Can see shaky hands, problems with balance and walking, difficulties with speech. You have Lewy body dementia. Lewy body dementia, usually you're going to have kind of those Parkinsonian-like features, usually some form of sleep disturbance, and cognitive decline is pretty common there. Vascular dementia, I like to think about this as like stepwise deficits that occur. So someone has a stroke or other vascular insult, and with each of those, there is a stepwise change in a negative way in their cognitive function. And then the one that's not listed here is, again, if you have something like Creutzfeldt-Jakob disease, which is a progressive, rather quick onset of dementia. So again, there are a lot of things that can help us. I think onset really helps you a lot. So certainly something that's more slow onset happening, somebody in the sixth, seventh, eighth decade of life, you're going to think more Alzheimer's there. Something where, they had a vascular event and then all of a sudden now they're having a stepwise worsening of, their mental status and things, would think more kind of vascular dementia. Um, Lewy body. What is interesting here is that often you're going to see kind of this slow onset over months to years. They might have RBD for years preceding cognitive impairment. I will say the visual and other hallucinations are kind of a key feature with that. And then frontal temporal dementia, the main one that I always like to throw out there is major personality change, disinhibition, apathy. Why? Because that is controlled by the frontal lobe. And so in frontal temporal dementia, where that is more impacted, we tend to see that a little bit more as compared to, Alzheimer's disease more affecting the hippocampus. So let's think through anticholinesterase inhibitors in Parkinson's disease dementia versus dementia with Lewy bodies. Anticholinesterase inhibitors here, you can see improve activities of daily living, cognitive function, behavior, and overall global assessment in Parkinson's disease with dementia. It's unclear the impact of anticholinesterase inhibitors in dementia with Lewy bodies, although rivastigmine and donepezil have been used sometimes in these patients. Antipsychotics, however, are a little bit of a different story. So patients that have dementia with Lewy bodies can have an increased sensitivity to first generation antipsychotics and can almost create like this NMS like picture in these patients. And so as a result of that, if you do have to use an antipsychotic, you probably want to use a second generation, for example, quetiapine, also trade name Seroquel, because it has less risk for these extrapyramidal effects. And the key here is that because there's this risk, really the use of an antipsychotic in someone with DLB is if the patient is an imminent harm to themselves or someone else. Otherwise, you probably don't necessarily want to start all patients with dementia with Lewy bodies on antipsychotic. Now, one last case I'll walk you through. So this is Mr. A, 76, has hypertension, osteoarthritis. It's a new patient to the clinic. Wife reports had some gradual progressive short-term memory loss over the past 2 years. Started to have problems, the ability to manage the finances, pay bills. Previously enjoyed spending time in the kitchen to cook, but now is not able to follow more complicated recipes. And a previous physician diagnosed him with mild Alzheimer's and started him on donepezil. Wife has concerns that he's going to continue to lose his ability to complete everyday tasks and hopes that we can preserve, quote, what he has now for as long as possible. So I wanted to kind of think here for Alzheimer's, which is what this patient has, most effective non-pharmacologic treatments, pharmacologic treatments, and then how do you manage clinical effectiveness? So in terms of non-pharmacologic treatments, I want to orient here. So this is a Cochrane systematic review and meta-analysis. So, you're looking at a forest plot here. The line in the middle, or in this case, the standard mean difference, that this is the line of no difference, meaning that if things are crossing over it, there is no difference between the intervention arm, which in this case was cognitive stimulation, versus control. For each of the trials, there is going to be a measure of treatment effect, which is represented here by a square or of varying width, and then the confidence interval for that treatment effect is represented by the line. And what we look for at the end here is to see, again, what is the summary statistics, which is this diamond. So when we look at things such as, if there's any impact of cognitive stimulation or not on outcomes, data's overall kind of mixed. If you look at a specific subset of cognition, maybe a small impact by doing it. In terms of the memory scale, no significant difference. Again, it's crossing this line of no difference. The summary statistic on the global cognitive score, a little bit of difference, but we only have one study in a small number of events. So overall, from a non-pharmacologic standpoint, cognitive stimulation may be helpful. I don't think it's harmful, and I think anything we can do for cognitive stimulation, by all means, go for it. What about exercise programs as a non-pharmacologic treatment? So they've looked at cognition in trials. Unfortunately, no statistically significant difference with cognition here. So particularly if someone already has dementia, I can't necessarily say that exercise preserves what they have. I think it can be helpful for other things in terms of keeping them able to, move around and do their activities of daily living. The impact of exercise seems to be more before they get to the stage of dementia. And that's whether or not you use all trials or if you only select out those that have mild dementia. Still seems to be the same with exercise programs. And this is that point that I was raising here. Cognition, we don't really have an impact. It does seem to have an impact on their ADLs with the idea that if we're keeping them exercising, moving around, they're going to be doing those basic activities of daily living. For depression, I wish I could say there was an impact, at least in those with dementia, at least in this systematic review and meta-analysis, there was not. Now, there are a whole host of different drugs that can be used. We have the so-called acetylcholinesterase inhibitors. That's going to be donepezil, rivastigmine, galantamine. There's memantine, which is an NMDA receptor antagonist, and then there's a combo pill of memantine and donepezil. I put this here from a lovely JAMA review on dementia. I think most of us probably are familiar with, donepezil, used it a ton, usually start at 5 milligrams, can go up to 10 milligrams daily. Technically, the highest dose is 23 milligrams. What I wanted to kind of emphasize from this slide is, a few things. One, we tend to like to use donepezil a lot because it can be used across all stages of severity of dementia, which is very helpful. The other thing that I want to kind of highlight here is when you get to moderate to severe, that's when you're usually bringing in things like memantine. Now, the other thing I would highlight is looking at the side effects, nausea, vomiting, uh, issues, GI. This can be very important, particularly in our older patients who might already have issues with constipation, decreased PO intake. And so I will say if patients have that at baseline, I'm a little bit hesitant to start them on it because I know it can make it worse. So if I simplified it just a little bit, for pharmacologic treatment at all stages, you can use donepezil. From mild to moderate, you can use rivastigmine, galantamine. From moderate to severe, you can use memantine and donepezil. Now, there are contraindications to acetylcholinesterase inhibitors. The biggest ones are usually going to be cardiac related if they have known bradycardia, bundle branch block, sick sinus syndrome. Now, if people develop this on these drugs, usually they can respond to just taking them off. So, for example, you didn't know that a patient, had underlying, bradycardia. You started them, all of a sudden their heart rate went to 45. You could just take them off of donepezil, for example, and then monitor to see if heart rate improved. They don't always progress to, for example, needing a pacemaker or things. Just adverse effects in general for the acetylcholinesterase inhibitors, GI side effects come to my mind. We try to use them with caution in those with peptic ulcer disease, seizure disorder, urinary tract obstruction. For the NMDA receptor antagonists, more headache and dizziness. And they should really be used with caution in those with severe hepatic and renal disease. So I'm rounding out the end here, and we took kind of a whirlwind tour through dementia from, how do we distinguish normal aging, MCI, dementia, what are the different types, what are the workup? And so, help me make my conclusion slide here. Kind of what's some take-home things that you're going to think about for the diagnosis or management of dementia? Again, you can join at Slido there. You can also put it in the chat, but what's some important take-home points? And then I'll give some of my own, and then I'll stop for any final questions. It is quite complicated. It is quite complicated. Yeah, time is important. I will say in my own practice, making the diagnosis of dementia probably requires at least me 2, sometimes 3 visits to really get it right and make sure that I've considered everything, just with the realities of all the other things that we're taking care of in the clinic. So I totally agree. You definitely need the time to properly diagnose, patients and make sure um, that you're not reflecting Oh, yes. Oh, yes. Involve the family. They're going to give you the collateral information and things like that that are going to be important. I think it's also important to involve them in those prognostic conversations that, unfortunately, dementia is a progressive disease. And at present, we don't really have, I would argue, great therapies that significantly change the natural progression of it. It might slow it some. So I'll wrap up with a few. The few that I wanted to make sure is out there is that not all memory loss is dementia. They do need testing to see what's going on with their cognition and how impaired is it. The second point is that you don't need this large battery of tests to diagnose dementia. Probably would do good with the slums or mocha. And then when looking for some reversible causes, a TSH, B12 are probably a good start. Neuroimaging is not required in all patients with dementia, but certainly if they have neurodeficits, rapidly progressive neurologic symptoms otherwise, probably great to do. Make sure that you don't lump all dementia into one bucket. There is certainly Alzheimer's, which is common, but we do see people with DLB, PDD, and like progressive dementias, as we see with Creutzfeldt-Jakob. Donepezil can be used across all stages of dementia. And that's probably still one of the most common treatments, that I use. And then in terms of preventing dementia, probably the most important thing on the prevention side is being judicious with our meds and thinking about exercise. And with that, these are the references that I use, and I'm happy to take any additional questions.
Thanks for the talk. Very informative. Thank you for attending, everyone.
Absolutely. Well, I appreciate everyone giving me some time to talk about a topic near and dear to my heart. Certainly, if you have any questions, feel free to reach out at christopherjackson@usf.edu. But with that, thank again SMA for putting this on, and we'll see you next time.
All right. Thank you, everyone. Thanks, Dr. Jackson. If you found this content valuable to you, please consider joining SMA by visiting sma.org/membership or making a tax-deductible donation. Visit sma.org/give to support our mission. Thank you.